Hello, Priyam is ready.
Yes, sir.
1
I'm ready,
minute,
sir.
let me go live YouTube, then we'll start. I'll let you know. Once it
Okay,
is
fine.
live, we'll start then.
বিরাজে হেরিদি দিবা ওয়েলকাম করে দিবা
Yeah.
We are live now. We can start our proceeding. Over to Beers, sir.
Yeah. Good evening, everybody. So, like earlier, we are doing this program, CME, and today we are welcoming Dr. Priyam as a speaker, and Dr. Menon, I think.
Yes, sir.
Yeah, so he is our expert, and other two fellow, Dr. Pradeep Saikia and Dr.
Ashok Das.
Dr.
Ashok Das.
Ashok Das. I would like to welcome you all to start this program. I'm really thankful to you all for coming here and joining with our CME. Thank you. Thank you very much.
Yeah, Dr. Anjan, kindly introduce Dr. Jaikumar Menon, our expert.
Thank you, ma'am. Today with us, Dr. Jaikumar Menon, sir. So this is my privilege to introduce Dr. Jaikumar Menon, sir, who is the first exclusive laryngologist of our country. He is well known all over the world, and presently he is the director of laryngology group in Trivandrum. His special interest in neurolaryngology, declutology, and professional voice care. He has got more than 25 publications and has contributed many chapters in laryngology textbooks. He is also a co-editor of Dysphagia in Head and Neck Cancer and senior author of Voice Therapy Simplified, a laryngologist perspective, and another book called Swallowing Therapy Simplified, a laryngologist perspective. He described the diagnostic sign for abductor spasmodic dysphonia. Menon sir is running an laryngology fellowship program. This is accredited by APSI. So with that, I welcome you, Dr. Menon sir. So for being the honored expert in our Nevoy classroom. Welcome you, sir.
Thank you. I'll be here. So let us listen to Priyam. Then we'll have a discussion at the end. I think we can go to the talk straight away.
Yeah.
Then we can actually do it.
Yeah.
Okay,
good evening and welcome to Neboy Classroom. Today's speaker is Dr. Priyam Sharma. I am just giving her a small, some brief biodata. She has completed her MBBS from GMCH, Guwahati in 2009. She completed her post-graduation in 2015, and I am very happy that she was my one of the postgraduate students while I was in medical college. She served as resident in Borpeta Medical College for a short period. She did observership training in laryngology under Dr. Jaikumar Menon at Trivandrum. She is currently ENT consultant at Nightingale Hospital, Guwahati. Her subject of interest, evaluation and management of swallowing disorders and phonosurgery. Welcome, Dr. Priyam. We have two moderators, and they are Dr. Pradeep Kumar Saikia. He passed MBBS in 1986 and MS in 1990. He did fellowship in head and neck oncosurgery at Tata Memorial Center, Mumbai in the year 1997. Presently, he is practicing ENT at Jorhat, Assam. Our other moderator, Dr. Ashok Kumar Das. Presently, he is the professor in the Department of ENT and Head and Neck Surgery at B. Borwa Cancer Institute. He did fellowship in Head and Neck Oncosurgery from Tata Memorial Hospital, Mumbai from 2003 to 2005. He is trained in transoral laser microsurgery from Prince Ali Khan Hospital, Mumbai. He went to Memorial Sloan Kettering Cancer Center, Newark, under Indo-American Fellowship in 2017. Dr. Das has 42 indexed publications and 3 book chapters to his credit, and he is also a reviewer of many national and international oncology journal. Dr. Das has keen interest in community awareness and screening program of anti-tobacco activity. Now I invite our today's speaker, Dr. Priyam Sharma, to make her presentation. Our topic is tracheostomy and swallowing. Over to Dr. Priyam Sharma.
Thank you so much, Khanna ma'am, for the introduction. Today's topic is a very new one on the horizon, tracheostomy and swallowing. So we both know about this topic in separate categories. We have been studying this since PG days. We all know about tracheostomy, and we all know about swallowing. But what is the interrelationship between these two different things that we see in our clinical practice is the topic that I'm going to be talking on today. At the very onset, I would like to pay my regards to all my teachers on the occasion of Guru Purnima, especially Menon sir and Count sir. So I'll just start with the topic. Just a brief history of tracheostomy before we go on to the topic proper. Tracheostomy is basically a tract from anterior neck of skin to the internal lumen of trachea to get a good airway for the patient. It was earliest mentioned in Egyptian writings from 3600 BC and also mentioned in various religious Hindu texts. The father of medicine, in fact, Hippocrates, he condemned the procedure because he thought it was too risky to be injuring the carotid arteries while doing the procedure. But of course, at that time, the anatomical knowledge was most probably not that good enough. And today we have advanced much in terms of anatomy. So we are very fortunate to be causing less problems while doing tracheostomy. Asclepiades of Bithynia performed the first non-emergency tracheostomy mentioned in history. And today's tracheostomy technique that we do, layer by layer, the surgical technique, is the work described by Chevalier Jackson, a name we are very familiar with in terms of laryngoscopes and other things. About the introduction, the brief relationship between swallowing and tracheostomy. But dysphagia is actually kind of a sequelae of tracheostomy. So some kind of dysphagia is to be expected in all the tracheostomized patients. The degree may be less, the degree may be more, but some kind of dysphagia is going to happen due to various reasons that we are going to talk about in the talk later. Literature says 50 to 83% of tracheostomized patients will develop dysphagia in some form or the other. And the degree is exacerbated by the degree of illness, the actual illness the patient is having, whether it is a stroke, whether it is some kind of oncology. So the degree of comorbidities of the patient will also affect the kind of dysphagia the patient is having. In history, there is blue dye test, which was first mentioned in 1973 by Cameron et al., who identified aspiration in tracheostomized patient. They basically placed Evans blue dye in the patient's tongue, and they looked for aspirated secretions in tracheostomy. And if the blue dye came across as blue secretions in tracheostomy, so there was some kind of aspiration going on with the patient. So it was a very good bedside procedure to determine aspiration in tracheostomized patients. What are the cases that we encounter in our clinical practice? The patients who are coming with tracheostomy. So who are the patients who are coming with these cases for us? We have basically two broad categories, neurological and head and neck oncology. So what about the neurological? We have the traumatic brain injury. We have post-stroke patients, post-cerebrovascular accident. And sometimes, but not very commonly, we see in chronic degenerative diseases, motor neuron disease, Parkinson's disease. Now, when we come to head and neck oncology, it can be either temporary, like as we know, we are dealing with the airway part of the person. So if we are planning a surgery, if we are planning a big surgery, so we expect some kind of edema in the post-operative period for the patient. And during that edema time, we have to have a tracheostomy to secure the airway for the patient. Sometimes the patient, after all the treatment is over, whether after radiotherapy is over or after surgery is over, the patient may have airway difficulties, and these patients might require a tracheostomy for a longer period of time. So this is a basic categories. There may be other patients also, but commonly these are the categories of patients that we encounter who are tracheostomized. Now, what are the indications of tracheostomy? the tracheostomy, as we have already read in our PG days, is basically about airway obstruction. It can be neurological, it can be oncological, it can be traumatic for the patient. Tracheostomy also is done in prolonged ventilatory support. So as we all know, we have done tracheostomy practice in ICU patients. If intubated for a very long time, tracheal problems happen in this patient, tracheal stenosis and all. So to avoid these problems, a non-emergency tracheostomy is done in such patients. And also for pulmonary toilet. So basically, we are managing tracheobronchial secretions in this patient. Now, this group also includes those patients who are having undetected salivary aspiration. So this is really helpful in those patients who are not able to clear out their own saliva. And by doing tracheostomy, at least we are managing the secretions and preventing them from going into the bronchial tree. Very briefly I would like to talk about swallowing physiology, because before knowing what is abnormal, we have to go through what is normal. So there are basically 3 phases of swallowing: oral, pharyngeal, and esophageal. And tracheostomy obviously hampers with the most important one of them, that is the pharyngeal, because this is the one where airway and food way, they come into cross connection. Very briefly about pharyngeal phase. So pharyngeal phase actually involves about 4 parts: the elevation of larynx, the retroversion of epiglottis, the adduction of aryepiglottic fold, and adduction of ventricular and the proper, the true vocal folds. So as you can see in the video, the epiglottis is retroverted, the larynx is going up during this procedure. And while the larynx goes up, the cricopharynx will open up here and allow the food bolus to go into the esophagus. The first step that I have mentioned, the elevation of larynx, is probably one of the most important steps, and I'll come to this later in the next slide as to how tracheostomy affects it and why its affection means so much for the patient. So this is about the hyolaryngeal elevation that I was talking about in the previous video, one of the most important steps in the pharyngeal phase of swallowing. So what are the muscles responsible for this? We have the suprahyoid group of muscles, the geniohyoid, the anterior belly of digastric, the stylohyoid, and the posterior belly of digastric. Now, if I play the video, you can see this is a video fluoroscopic study of a patient. I got this video from the internet. It's a very simple video actually, but it shows very clearly what is the relationship between hyolaryngeal elevation and cricopharynx. So these are the 2 areas that we need to be looking into when the larynx elevates and when the cricopharynx opens. This is just about the anatomical landmarks that they are showing in the video. So you can see the patient is given bolus. So this is a video fluoroscopic study, and you can see the larynx is lifting up. And for the brief second, this part of cricopharynx opens up. So here there's a cricopharynx, and this is a slow motion part of the video. You can see very clearly the larynx goes up, and at that time only the cricopharynx opens up to allow the bolus of food to go into esophagus. So since we all know that this part is so important for the patient to have, so how tracheostomy will affect it, I'll come into the next slide. So what are the effects of tracheostomy on the swallowing of the patient? The first effect is going to be immediately after the surgery is done, patient is going to be having pain around the tube. And unless that is very nicely managed, the patient will obviously have difficulty in having food. The other 4 are more difficult to manage, but we'll come to that one by one. First of all is airway pressure changes, the loss of subglottic pressure, because obviously the airways open from beneath the vocal cord, so subglottic pressure is not going to be maintained. Decreased laryngeal motion, very obviously, because the tracheostomy is something we are attaching around the skin of the patient. So it is obviously going to hamper the laryngeal elevation to some extent. Decreased glottic closure, because the airway pressure is less, the glottic closure is going to be affected. And lastly, desensitization of the larynx and subsequent loss of the protective reflex, because over a long term, if the airway is closed, it will cause the sensory inputs to be lessened. So we've come to the first change that happens in tracheostomized patients, that is airway pressure changes. So in normal patients, it has been documented that subglottic manometry has been showing presence of good subglottic pressure during swallowing, and which is lost with open airway in tracheostomized patient. Also, there is loss of nasal resistance and resistance at the lower level of vocal cord. So, as we all know, swallowing is an expiratory process. So, because of the loss of resistance at these levels, the swallowing greatly hampered in this patient. Also, it prevents effective cough and alters normal glottic closure responses in this patient. So what can we do about it? So there is one very simple thing that can be done in this patient is the deployment of a speaking valve, expiratory speaking valve. So the simplest thing that we can be done in patient is decannulation, but of course that is not possible in all the patients. So speaking valve is a very good idea in this patient. So what happens with the speaking valve, as you can see in the image, the air goes into this way, but while coming out, there is a valve which prevents the expiration through the tracheostomy. So the air has to preferably go through the vocal cord. So it obviously improves the subglottic pressure. It helps the vocal cord to close while swallowing, and it helps the patient to have a safer swallow than a completely tracheostomized patient. Laryngeal elevation. Now, we all know in this picture, as you can see, larynx is tethered, it is anchored by tracheostomy, and it is because laryngeal elevation is so important to open up cricopharynx. So some kind of elevation hampering also means the cricopharynx will not open up nicely. And when the cricopharynx doesn't open up nicely, the food will not be able to go into esophagus. And whatever residue food is there, it will trickle down into the laryngeal inlet, causing aspiration. Now, the presence and absence of cough comes into the question. So ideally, if we think about it, we always think that the cough presence will actually prevent aspiration. But if you are actually talking about anchoring the larynx, presence of cough inflation actually further anchors the larynx. So ideally speaking, a bit of cough deflation is not bad for the patient swallowing to happen. Pharyngeal transit time. So typically in a normal patient, what happens? The bolus transit from base of tongue to esophagus, it takes less than 1 second. But in presence of a tracheostomy tube, the transit time is increased because of the restriction of range of movement of pharynx. And it results in food pooling in pharynx while the glottis is open. So some amount of food can always go into the larynx while the food is waiting there for going into the esophagus. Impaired glottic closure, again, it's related to the first point that we discussed, absence of subglottic pressure. So there is glottic closure is affected, which is a basic reflex and takes 44 milliseconds in a normal patient. Lung protection is done by cessation of respiration and glottic closure. So this part is totally affected when the glottis is not completely closing during swallowing. This is mediated by the internal branch of superior laryngeal nerve. This reflex glottic closure is basically a reflex. So you don't have to think about doing it. It will naturally happen in patients who are swallowing. It's a reflex triggered by sensory receptors on supraglottis. There was a study done by Sasaki et al. Who demonstrated increased in reflex threshold in tracheostomized patient. Then we come to the last point that happens when tracheostomy is done. It causes desensitization of the larynx. So this is basically caused by lack of airflow in upper airway. So if over a long term, if no air movement is doing in the upper airway, so the sensory reception is going to be affected in these patients. Potential nerve damage during the tracheostomy surgical procedure itself, and sometimes presence of T-tube itself, especially with cum inflated, will cause more desensitization of the larynx. So we all know what problems tracheostomy can cause in patients, how to go for assessment. We have been called to see a patient who is tracheostomized, and we have to take an assessment of dysphagia status in this patient. So before directly going for any examination, first of all, we'll talk about history. So this is very important in cases of patients who are not in hospital, but in some rehabilitation centers. Then we have to take history from the caregivers or the family members. The current feeding practices, whether the patient is able to have something or not, whether they want to have something or not, whether they're opening up mouth or not. Sometimes they are not very keen on taking food. So that is also a very big negative factor. Documented aspiration episodes. If sometimes the patient has already been hospitalized for aspiration pneumonia, so that's a big negative factor for the patient. Desaturation events. So if the hospital staff or the center staff says that we have seen dip in SpO2 after feeding and all, so these things have to be kept in mind. Increased need for suction. I find it very helpful in patients who are not very helpful for endoscopy. So if the staff says or the patient's family says that while at night when the patient is sleeping and we hear a lot of gargling sound from the throat of the patient, and we have to put a suction through the oral cavity of the patient to clear out the secretions. So that indirectly means that there is salivary aspiration happening. And apart from tracheal suctioning also, oral suctioning is required in this patient. The second part is risk factor analysis. So mental status, as I said, whether the patient's cognition is good enough to go ahead with any test or not. Presence of pathological refluxes. Trismus, the patient does not open mouth, or even if he wants to, he cannot. Bite reflex, the patient continuously biting down on whatever things you're giving in the oral cavity. Presence or absence of spontaneous swallow, any associated cranial nerve deficits, and presence of voluntary and reflex coughs. These are very good indicators in patients who are going to be assessed by you. In the physical examination, of course, we are going for the general examination, how is the nutritional status of the patient, and we are going to see all the cranial nerves, special emphasis on the 10, 11, and 12th cranial nerves. Then we come to the more clinical part, management of secretions. So whether the patient is able to tolerate their own saliva. So as I said in the previous slide, the need for doing oral suction is a big indicator for in these patients. Also, blue dye test is mentioned hysterically. I don't think we are doing that much in clinical practice, but it's a good indicator of aspiration in this patient. Clinical swallow evaluation. So these can be done by a lot of speech language pathologists also at bedside of the patient. So we give some water or food to the patient. We look for wet vocal quality, so which means there is residue, and presence or absence of reflex cough after we are giving the bolus. So this is completely clinical. There is no instrument involved in this stage. And then finally, we have the more confirmatory test like the FEES and video fluoroscopic study. And FEES, I think, is very helpful in this patient because a lot of these patients are non-ambulatory and very difficult to get a VFS in this patient. So we'll just see what can we do with FEES in decannulation of these patients. So traditionally speaking, when decannulation was discussed, we always thought about whether the patient can breathe after decannulation. Traditionally, we have always been asking this question. But nowadays, one additional question is being asked, and whether the patient can swallow if we do the decannulation, and whether we should go ahead with decannulation, keeping in mind this patient cannot swallow normally. So there is a protocol which is observed, and I was very lucky to get this in a book written by Menon sir only. It was a very well thought and very well described protocol, Wernicke's protocol. So when we do FEES in this patient, there are 5 things that we should be see, 5 levels to be precise. So level 1, level 2, level 3, 4, and 5 in the next slide. So the patient has to clear all the levels to be in order to be eligible for good decannulation. The first level that we see in this process in doing FEES is whether the larynx is visible or it is blocked. Like in this case, you can see this is the rice tube, this is the epiglottis, and the larynx is completely covered by saliva. So in this patient, since there is no visibility of the larynx, there is no point in going to level 2. So here only we can decide that the patient is not fit for decannulation. Suppose this is not the patient, suppose this is all visible, all is clear, then we go to second level. What is second level? Look out for whiteout sign. So what is whiteout sign? I'll just show you this video. This is a normal patient. At point, the tip of the scope touches the pharyngeal walls, and there is a point where you cannot see anything. So this is whiteout sign. Absence of whiteout sign will mean that the laryngeal elevation is greatly hampered in this patient, and then the patient is not eligible for decannulation. In case whiteout sign is present, then we go to the third stage. That is checking of the laryngeal sensation and cough efficiency. So how do we do it? We just touch the tip of the scope lightly on the arytenoid process. The touch should not be very rigorous, otherwise the patient will have a very violent cough reflex. So lightly touching the tip of the arytenoids with tip of the scope and looking for laryngeal adduction, whether the vocal cords are adducting after we touch the arytenoid. So in case the sensation is present, then we go on to the next level, the level 4. So what is level 4? We give semi-solid food to the patient, solid or semi-solid food, and we look for presence of aspiration or penetration in this patient. So if there is no penetration and no aspiration, then only we can go to the level 5. If there is significant aspiration or penetration present in this level, then we have to stop and decide against decannulation in this patient. And the last level is giving liquid food to the patient. And after that, if there is significant penetration or aspiration, then again decannulation is not advised in these patients. So this is a protocol that I think we all need to follow before decannulating any patient. It will save a lot of re-tracheostomy introduction and a lot of aspiration pneumonia in these patients. So what is the take-home message that I have been trying to give? If dysphagia is a sequelae, and some kind of dysphagia is always to be expected in tracheostomized patients. More studies are needed because this is a very new subject on the frontier, and a lot of sensitization among the public and the doctors needs to be done regarding this. Also, a lot of speech language pathologists need to be involved. And decannulation protocol, I think, should be more streamlined so that it's easier to follow, not only in tertiary centers, but also in primary centers as well. My references are these two books. I find them very helpful. And the second book is by our own Menon sir, and it's very simple and very easy to follow. With this, I would like to conclude my presentation. It was a short presentation, but I hope it helped everyone. Thank you.
Thank you, Dr. Priyam, for your wonderful presentation. Now over to our expert, Dr. Jaikumar Menon sir, for your input on her presentation as well as your input on this subject.
Yeah, I think in a very short period, Priyam did a very good job of covering the essential part of swallowing disorders, how to manage it, especially that that stress zone, which many people don't know. Because when you talk about the decannulation of a tracheostomy, there are two aspects. One regarding the airway, whether the airway is safe for tracheostomy to be decannulated. That is what most of the ENT surgeons know. So they know that they will actually they will put the tracheostomy, they will cork the tracheostomy, and if patient is able to breathe without any problem, that is fine for airway. But what most people are not aware is that actually the swallowing safety. So when a tracheostomy can be removed, this is very, very important because this is sort of a double-edged weapon like the gun, because tracheostomy itself will actually cause problem with the swallowing. So you have to use a very fine judgment. Sometimes in borderline cases, removal of the tracheostomy may be useful in improving the swallowing, but it can never be at the expense of the patient's safety. So if there is a risk of aspiration, you have to be very, very careful in decannulating. That is why Wernicke described that protocol, which Priyam did explain very well, that up to that 5 level. Level 1, you do the scopy. If you can't see the larynx, that is not fit for decannulation. If larynx can be seen, then you go to level 2. That means where you are assessing the larynx movement, the white out sign. If the larynx is immobile, larynx is visible throughout the scopy, then that is a dangerous thing. Patient is not fit. Third is actually then you go to the laryngeal sensation and cough efficiency. That is also very important. And fourth is then you give semi-solid diet and look. And finally is liquid. I many times skip the level 5, because what I've seen is that if the patient is able to swallow semi-solid without much problem, and the patient has got some problem with swallowing liquid, I will actually try to, if the patient is relatively younger, that means say less than 60 years and the lower respiratory tract is good enough, I will actually take out the tracheostomy, because I'm sure that I can make them take food in a semi-solid diet and can have supply that kind of the amount of liquid through a semi-solid diet. And then I can actually teach them the techniques like supraglottic swallow, so that he can actually take liquid. So many times, if the young patient, if the lower respiratory tract is good enough, I will actually stop at the level 4 of Wernicke's protocol. That means patient is swallowing semi-solid without problem, only thin liquids are problem. So I will then tell them that, okay, you can take out the tracheostomy, take thick liquid, like don't take water or tender coconut water, which is very, very thin, but take semi-solid, like thick and liquid, like very thick tea, coffee, kanji water, all these things can be taken. So that's actually, but that's a very good protocol to do the thing. I think, yeah, there are a few questions. Priyam, if we can answer, that is great.
Yes.
If needed, I can help you.
Okay, sir.
We have two moderators here. Dr. Ashok Das from BBCI. Can you add your input here? You can start your video.
Good evening, madam. Can you hear me?
Yeah,
Am I
you're
audible?
audible.
Madam sir, good evening and good evening everyone. I'm so sorry I joined little late. Priyam has very nicely conceptualized this thing, and even we do tracheostomy, the tracheostomy related dysphagia is a very, very important aspect. But more important is that the indication of tracheostomy we have done. And from my perspective, most of the tracheostomy cases related to radiation, I mean to say, indications are malignant disease. And what we experience is that uh, tracheostomy related to radiation make the scenario a little worse than the other indications. So in that case, it's little longer. It's very difficult to rehabilitate and decannulate. So this is our experience. Thank you, madam. Thank you for this opportunity to get me. Thank you.
We have another moderator here, Dr. Pradeep Kumar Saikia from Jorhat. Over to you, sir, for your input.
Hello, actually my video is not working properly. It's starting. I think audio is okay.
You're audible.
You're audible, fine.
Actually, I have some I mean, that is the latest part which Dr. Priyam has shown is interesting. Most of the time, the swallowing part is ignored. I mean, because everybody is looking at the airway, not the swallowing part, and most of the time patient is on rise tube, so that part is ignored. But the swallowing part is also very important for tracheostomy patient, and it is as Dr. Priyam has shown it very nicely. And the main cause is the absence of subglottic pressure because of the tracheostomy and the loss of elevation of the larynx. That is interesting, and that decannulation part was also very much interested. So I think that is helpful for all of us. Even I have learned something. But in our oncology cases, as Dr. Asuk has already mentioned, post radiotherapy, post operative cases, these are not always, suppose this recannulation procedure, the 5 steps she has shown, these are not always possible in all cases because so many other factors, disease recurrence, post radiotherapy effect, so many things are there. Anyway, it is a very good paper, very good. She has explained this very nicely, and I think people are benefited from this. All our, I mean, those who are present here, all are benefited from this talk. Thank you, Dr. Priya.
Thank you, sir. There are some questions by those. Should I address them?
Yeah,
in the
if
chat
you
box?
have
Yes,
access,
sure.
you can just read it out and try to.
Yes. Fukan sir has asked how many muscles work in process of swallowing and how they coordinate. How they coordinate is going to be long, but I think 30 plus something. I forgot the exact number. Fukan sir is having his favorite question is this. More than 30 muscles. I'm not sure about the correct number, but more than 30 muscles are there in the whole process of swallowing from the oral cavity up to the esophageal phase. Am I right, Fukan sir?
Fukan sir, can you unmute yourself?
I think it is, I don't know actually, somewhere I got it is 20 muscles and one unpaired, I think. I have also forgotten. Just to for you, I know you, therefore I'm putting. I
Yes.
think it is 20 muscles, paired muscles, I think, and one unpaired, I think.
Okay. Okay. Khanna
Sir
ma'am,
will know.
yes, yes,
Like
sir.
much.
Khanna ma'am is asking what is supraglottic exercise in dysphagia? This is actually a therapy, kind of therapy, which is direct swallowing therapy. I will just talk about swallowing therapy very briefly. There are two broad categories. One is indirect and one is direct. Indirect is when the patient is not actually having food. So while they're resting, they're doing something else. They're just doing some exercises to strengthen their muscles of swallowing. Very good example is given in Menon sir's book. Like if suppose Virat Kohli is a batsman for India, right? But he's doing some other exercises, like he's doing jogging, he's doing weightlifting. He's not training directly for cricket, but these exercises will help him build up muscles to play cricket. So indirect therapy is like that. The second group is direct swallowing therapy. So this is when Virat Kohli is actually practicing cricket in the nets. So he's actually preparing for the major match. So direct swallowing therapy is when the patient is actually eating food and then only he can do some modifications while he is having food. So supraglottic maneuver is one of the direct swallowing therapy. So what happens? The patient is instructed to take a deep breath first and then hold the breath and then put food in mouth and then swallow and then when expirating he is supposed to give a voluntary cough. So these are 5 steps of supraglottic swallow and very helpful in patients who are having a bit of aspiration. This is supraglottic therapy in dysphagia.
Okay, thank you. I think it improves the airway protection during swallowing, right?
Yes, ma'am. Yes.
Yeah, thank you. Thank you.
The next question is, if I'm not missing anything in this, yeah. B.N. Sharma sir has said decannulation protocol is informative and interesting. Yes, I agree because we were not aware of this until we read Menon sir's book. We had a haphazard idea, but the tabulation actually helps in making very good decisions while we are going for decannulation. So yes, I agree with you, sir. Fukan sir asks how to detect the muscles responsible for swallowing problem. Will EMG help? Yes, this is actually a very good question. Menon sir, I think would like to help me out in here. If you're asking about me, I will let fees decide that for me, which kind of muscles are affected. But Menon sir, is EMG helpful in these conditions?
Yeah, because many of the time we can actually see the activity, like, because the muscles involved. Say, for example, to see the muscles of the oral aperture, that is orbicularis oris, buccinator, the tongue muscles, the floor of the mouth muscles like the mylohyoid, geniohyoid, and the stylohyoid digastric complex. That all we can actually see. So there is actually no need palatoglossus and palatopharyngeus. So mainly EMG is nowadays used mainly for the problem area, that is the inferior constrictor. So in pharyngeal dysphagia, inferior constrictor is actually a big problem muscle because it is actually a very compound muscle. It has got a thyropharyngeus, it has got a cricopharyngeus, and that their coordinate action is a must for swallowing. So EMG, laryngeal EMG is mainly used in swallowing for the inferior constrictor. So if you've got a double channel EMG, not everybody will have that. If you got a single channel, you can actually put one needle into the cricopharyngeus and see whether it is actually contracting or relaxing. And you can also put it in the thyropharyngeus. Then laryngeal EMG also is known to can be done, but the role of laryngeal EMG again is not very great in swallowing disorder. So I will say that the importance of laryngeal EMG in swallowing deglutology is mainly concentrated around the inferior constrictor. So especially and more so in cricopharyngeus part of the inferior constrictor. Thyropharyngeus also can be done. In addition, you can also do it in laryngeal muscle, but predominantly in swallowing, it is about the cricopharyngeus.
Okay, thank you, sir. Bhashwati Mahanto asks, is the decannulation protocol same for adults and children? I'm not very sure about this, sir.
Yes, same. And because in pediatric age group, you have to be even more strict because in every swallowing disorder, the most important step is that that aspiration shouldn't happen. Because there is no point in trying to be a little bit aggressive and start swallow therapy or give food and end up having an aspiration which will take back the condition back because patient will actually develop pneumonia, aspiration, hypoxia, all this actually it will affect the brain function. So that is not there. In children also, same rule. Actually, we have to go if the decannulation, mind you, we are talking about a decannulation in a swallowing function. We are not talking about the airway at all. So when you are swallowing function in children, it is all the more important that we actually follow the Wernicke's protocol, that level 5, the 1 to 5 level Priyam talked about.
Yes. Dr. Kuddush Ahmed sir has just mentioned, described the problems that can be encountered after tracheostomy. This is not exactly a question. He has just made a comment. The stress on the 5 steps to look for suitability of decannulation was very informative and should be useful to be kept in mind when decannulation problems are anticipated. Yes. Yes, Ahmed sir has just said what Menon sir has just mentioned about EMG. The single muscle involved in swallowing, as Dr. Fukan, is probably the cricopharyngeus. Is that correct? So yes, Ahmed sir, you were correct, sir. Absolutely. Like, this is the most complex muscle we encounter, so EMG is going to be helpful with that. Dr. Anjan Bhuya is asking, while decannulating in non-obstructive cases, if fiber optic endoscope is not available, what is the best and earliest clinical indicator for eligibility of decannulation?
I think rigid scopy will not actually say that because you are not in a physiological assessment of the code. So rigid scopy is actually a poor replacement for a flexible laryngoscopy. Actually, in a swallowing clinic, a flexible laryngoscopy is a must. Of course, what are the other alternatives? You don't have a flexible laryngoscope, then you can actually visualize the larynx with a rigid laryngoscope. But then you can utilize the fluoroscopy more efficiently, even though nowadays the use of fluoroscopy is actually being a little bit limited because we don't want excessive radiation. But if flexible laryngoscopy is not there, then fluoroscopy is actually going to tell you that. And the advantage of fluoroscopy over FEES is that it will always quantify. So sometimes in flexible laryngoscopy in FEES, you may think that there is some aspiration, but you don't know how much amount went down because you are looking from above. It is actually end-on view. But in a fluoroscopy, you are actually seeing the side, you are looking from side. You are looking from the side of the trachea. So, you know the amount of aspiration happening or the absence of aspiration. So, if flexible laryngoscope is not available, rigid scope is not actually a good equipment for non-obstructive cases of decannulation. But I think I will say that fluoroscopy is a better alternative.
Sir, is clinical evaluation enough? Like sometimes if none of these is available in a lot of primary care centers, is clinical evaluation enough for decannulation?
Yeah, I think he asked, I will come to that, but the dynamic MRI is a great, but the expense. Dynamic MRI is okay. It is actually a good thing, but the expense is considerable. So I don't think we will actually go for that. Fluoroscope is a thing. Now, Priyam's question of doing clinical evaluation. I think that's a standard pattern. What we should do is that a sort of a triage thing, because in a center where there is a lot of swallowing disorder, it's like a hospital which has got a big number of neurologic patients, or a big neurology department, big neurosurgery department, big head and neck surgery department, big radiotherapy department, the number of cases will be very, very high. So then comes the concept of triage. So the swallowing pathologist or the laryngologist, whoever is there, actually has to take a round, and we have to do the triage and convert and divide this group into 3 patients. First patient is very clear cut. You know that patient doesn't have any problem. Patient swallow very well. The clinical evaluation of the swallowing is normal. There is no history of aspiration pneumonia, nothing, and on swallowing, you connect just a pulse oximeter and everything is okay. You can actually dismiss that patient. There is no need of an instrumental evaluation. So the group 1 doesn't require anything. When everything looks all right, patient swallows normally, no history of aspiration pneumonia, and you connect a pulse oximeter, everything is okay. Fine. They need not require any instrumental evaluation. But there is a 2 group, group 2 and group 3. Group 3 is very clear cut. Patient is aspirating. History of aspiration pneumonia, patient cannot swallow, patient is violently coughing. They are the other extreme. They definitely require instrumental evaluation to go further. But the problem group is actually the group 2, where patient is swallowing all right, patient is not coughing, but there are some suspicious signs, whether the voice is not very great. Is he aspirating? If a silent aspiration is there, so then that group also require instrumental evaluation. How do you know that? You actually put the pulse oximeter on the patient's finger and make them swallow. And if there is it is not a drastic dropping of the oxygen pulse oximetry, but if the oxygen saturation is dipping when patient is taking food, especially that 5 ml water, 10 ml water, 15 ml water, like that, if you add to more than 30 ml water, patient is taking, there is some amount of desaturation, then that is that middle group. You are not very sure that patient swallow is safe, and neither are you very sure that patient has got a very frank aspiration. So somewhere in the middle group. So these group also require instrumental evaluation. So group 1 doesn't require, group 2 and group 3 require instrumental evaluation.
Okay. Sir, what is the experience with speaking valve, sir, in this patient?
Speaking valve actually do, especially in a child, it is, if they're tolerating, it is great, because for one of the as the earlier step in decannulation, we actually close with the speaking valve. So it gives the voice, it gives some kind of positives. You know that one of the problem with the tracheostomy is that the negative, there is no positive pressure. So it gives some amount of positive pressure, and you also get a rough idea that this may be good, but that's not a complete answer. For the beginning, you can start.
Okay. Just a
Yeah,
question.
I saw a question where radiologist is not willing to stay. I don't think actually there are very few radiologists who actually who are interested. Only if they are interested, they will actually develop expertise in swallowing evaluation. I think we should do it,
Yes.
not them.
Yeah. We were talking about 2 groups of patients, sir, oncological and neurological. Personally, which group do you feel, sir, is more difficult to manage?
Yeah, that's a question I usually ask more people. There are advantages and disadvantages, but I still feel that I both are difficult, but I still feel that the neurological group are relatively easier. The problem is that in head and neck cancer group, there are two issues which are going against. One, you have distorted anatomy. They have either taken out, the surgeon has taken out, and there is the added insult of the radiation and chemotherapy. That is one. Second, the word cancer, the effect, the psychological impact of the patient. I'm not every patient is same, no, but many patients become, no, they are not, they're not, their attitude to that positive attitude may be missing. This is a generalization. I'm sure that exceptions are there. Coming to the neurology group, there are two groups. That is very, very important to understand. The acute brain injury group and the chronic degenerative disease. They are drastically different. So if I am to select, I will select the acute brain injury group as the best patient. Acute brain injury means stroke, trauma, where brain is injured. So the philosophy is here that the worst part of the swallowing disorder is over. So our aim is actually take out the Ryle's tube or the feeding tube by doing a rehabilitation, swallowing therapy, or phagosurgery, whatever it is. While in the second group, the chronic degenerative neurologic disorder, they are very bad cases. Nobody, we know that they are very difficult, like Parkinsonism, and the worst of all, the motor neuron disease. There, that the worst is yet to come. So there the paradigm change, the policy is that we will try to postpone the date as much as possible, for the introduction of a feeding tube. Ultimately, they all will require feeding tube. We are not going to make them eat normally. That is out of question. But acute brain injury, they are actually very good, very satisfactory group. Very, we get a lot of happiness and a positive thinking because we can make them eat normally.
Okay. So one last question from my side. This is actually included in your book, but I just want to hear from your side. Rice tube and tracheostomy tube, both are in one patient. So which one to take out first?
I think we know that the tracheostomy is actually a problem for swallowing, right?
Yes.
So whenever tracheostomy is not absolutely needed, take out the tracheostomy, right? Swallowing will be better. But how to decide? One easy way out will be follow very strictly what you told, the Wernicke's protocol, the level 1, level 2, level 3, level 4, 5. Another way of thinking is that you look, there are two groups where tracheostomy shouldn't come out early. They're dangerous group. Like when patient is an older patient, they have got poor lower respiratory, or at the extremes of age, very young children and very old people, because their lower respiratory reserve is very poor. So even a minimal aspiration will take the clock back. While in a middle age or a young adult, some kind of aspiration is acceptable. They will actually come out of it. So old extremes of age, better to take out the tracheostomy last. Make them swallow, rehabilitate, and then make them eat, and then only take. Second is that the laryngeal sphincter function is very doubtful, like a bilateral sensory paralysis. And partial laryngectomies, they are actually dangerous patients. Partial laryngectomy patients, they can actually have a lot of problem, especially if they, I mean laryngeal set, I didn't mean partial laryngectomy. When the sensation of the larynx is very, very bad, they actually, the neurological problem, they actually aspirate. They are actually very dangerous patient. So lower respiratory tract dysfunction, laryngeal sensation poor, extremes of age, they are dangerous patients. So in those cases, you actually take out the tracheostomy last. You take out the Ryle's tube. But in the other group, younger patient, relatively younger patient, you actually take out the tracheostomy tube. And the classical example will be the partial laryngectomy patient. Like the supraglottic partial laryngectomy, supracricoid partial laryngectomy, we do the tracheostomy and the Ryle's tube feeding. Usually, once it is healed, the swallowing take little longer time, and that will be better when you take out the tracheostomy. So in rehabilitation, when the laryngeal, the patient is younger, lower respiratory function is very good, and the larynx, the partial laryngectomy is all, you take out the tracheostomy first. And there is one more group, but which you probably don't come across very common, because people, now you might have heard about the concept of laryngeal renervation. So when you do bilateral laryngeal selective reinnervation for a bilateral cord palsy, again, we take out the tracheostomy tube first and then Ryle's tube. So I will, not complicating, I will just tell 3 points. Extremes of age, laryngeal sensation poor, poor lower respiratory tract, you remove Ryle's tube first and tracheostomy later. All other grape, you remove the tracheostomy earlier.
Okay. Thank you so much. That was actually very practical steps that we can follow in our day-to-day practice. These are my last questions. Anjana ma'am and Khanna ma'am, any words?
Now it is customary to give vote of thanks to the persons involved. First of all, I'd like to thank Jacob Menon sir for being with us in today's the NEBOI classroom. On behalf of members of NEBOI, I pay my regards to you for joining this class. And
thank you, a pleasure.
It is a wonderful presentation by Priyam. We all know that you are doing a great job in this field, and it was so nice to listen to you. And it's for selecting a topic. Actually, this is very will be helpful to all of us. And I would like to thank two moderators, Dr. Pradeep Saikia and also Professor Ashok Das for joining this classroom. And last but not the least, all the members who have joined this classroom online or through the YouTube channel of NEBOI Classroom. Thank you everyone for joining this classroom. We conclude our classroom here. Thank you everyone.
Thank you very much and good night to you all. Thank you.
Thank you. Good night.
Thank you.
Good night and thank you all.